without further ado, let me go ahead and introduce you to our chair for today, Dr. Zeenat Khan. Zeenat has been the Regional Chief Executive Officer for the Aga Khan Health Services in East Africa, where she leads a vast network across Kenya and Tanzania. She also holds the global portfolio as the head of quality clinical programs and projects for Aga Khan Health Services. In addition to that, she is also a consultant with JCI and brings over 30 years of healthcare leadership experience, particularly in the areas of hospital and nursing administration, quality improvement, and patient safety. She's also been a member of the International Hospital Federation's Governing Council since 2022, and she's definitely one of my favorite people to work with. So thank you so much, and please join me in warmly welcoming Dr. Zeenat Khan.
Thank you, Aditi. You are so ever kind. Hello, everyone. I am seeing the names of people who are here, and so nice to see some of the old friends I have met in IHF. In the last two IHFs, we have been together, once in Rio and in Lisbon. So, Karibusana, welcome, and Khushamded. It is my pleasure to be your host today and facilitate this amazing panel of speakers whom I'm so excited to introduce to you all. Before I jump into requesting our panelists to speak about, let us recap of what we have been talking about on under the umbrella of FHHS quality pillar. If you remember, as I mentioned, we have already met twice. Once we met in Lisbon, and then we met in Rio, and had some other webinars. Our thrust have been how do we bring quality on the table for the leaders of healthcare institutions and healthcare systems. We know, guys, that resources are always going to be limited. I wish we had a pot of gold sitting somewhere and we could just dig in and invest in our priorities, such as working towards quality structures, putting the right people, working towards AI, putting this, softwares, and so many more demands. How do we, as administrators, figure out the prioritization? How do we work towards a framework which helps us to decide where should we be investing? What are the challenges as healthcare administrators for us related to putting the right structures, putting the right framework, KPIs, clinical indicators. Last time, if you remember, we talked about what should be our minimum clinical monitoring indicators. So, this is what we have been thinking about and talking amongst ourselves. Today's webinar, we thought, why don't we have some case studies? Case studies around the world, talking about their experiences to talk to us. How did they start their journey? What were the motivators and demotivators? What pushed them to do it? What made them successful? What were the challenges? What did not work? And then looking at that, what are the learnings for us? We also wanted to present to you one of the quality framework. So one of our speakers will really present a framework of quality and patient safety, which has very successfully been implemented in LMIC countries. So that's what we are trying to achieve today. I also want to and hope that we will get some time to ask question to our panelists and talk about your issues, your concerns. And in fact, we might have some of you talking about where are you guys since we last met in Rio. What kind of structures did you put in place to improve your quality and patient safety initiatives? What have you implemented in terms of policy and procedures? And what have you implemented in terms of outcome and monitoring and clinical KPIs? So I'm looking forward to our amazing speakers and then also to our chatting and discussion about where we are today and where we want to go tomorrow. And if we are okay, I would like to. It's my honor and privilege to invite to introduce our first speaker, and that is Dr. Adolfo Linas. He is, I have to tell you, when we did, we also do pre-preparation. So I got a chance to meet Dr. Adolfo, and it has been such a pleasure meeting him and listening about his career, his institution. He is a very, very well recognized orthopedic surgeon. Now, how amazing is that, to have an orthopedic surgeon who has picked up and become a guru for clinical governance in his network and his institution? So, guys, here we are, listening to an orthopedic surgeon with amazing fellowships, with a great background of his studies in California, in Western, in the States, and now a corporate chief medical officer. And in the, sorry, Adolfo, I will be messing up your institution name, but you can read it, or you can tell me better than Foundation Center. Too much for me, so I will request you to tell me how to pronounce that. But what an amazing speaker, and your sharing your experience with us is, look, we are looking forward to that. Over to you, Adolfo.
Thank you very much, Dr. Zina. Thank you for that introduction. Thank you for all that passion. I hope I will live up to the expectations. So this is our institution. It's Fundación Santa Fe de Bogotá in Colombia. It's a private, not-for-profit organization, and I will tell you a little bit about it. I'm having trouble moving forward here with the presentation. Let's see what's going on.
Yeah, it's moving.
Okay, now we are. So give you a little bit of context about Colombia. This is our population is 52 million people. Our life expectancy is about 78 years. Our GDP per capita is about $8,000. The geography of Colombia is quite complex. We have 5 distinct subregions. We have jungles, extensive plains, very high mountains, and a few deserts. So we also have coasts on the Pacific Ocean and on the Atlantic Ocean as well. This is the appearance of our main campus in Bogotá, which is 2,600 meters above sea level, which is sometimes challenging from the point of view of healthcare. I'll give you just a snapshot of our institution, and I think, Dr. Zina, if I may provide some use to our attendees, we're actually a health system, but a small health system, which are not frequent around the world. We're going to be listening later to the Apollo hospitals, which is a huge health system. So ours is 2.5 hospitals. We're actually building our 3rd hospital. We work in 13 sites along Colombia. We have about 600 beds, about 28,000 inpatient cases. We do not have a physician system affiliation. We actually have a self-governing medical body, and I'll get back to that. We have about 5,000 employees, about $43 million in net revenue, and about 1.5 million patient encounters. The medical directorship has 1,350 physicians working in an academic structure. Now, I deliberately changed the sequence of the title because that's the way we see it functionally. And on one extreme, we have the mission, which in our case is very well structured, since we are a not-for-profit foundation. And on the other extreme, we have the competitive strategy. And in the middle, we have the medical model, which is the essence of my presentation. So our mission is not original. I think if you look around the world, you'll see similar missions. The way we go about it is perhaps what is unique and maybe of use to some of our listeners. So our mission is to lead and to influence positively the health sector of Colombia and the region in order to contribute to the well-being of individuals and the community. So the two active verbs here are to lead and to influence, and defining what those verbs mean is a lot of my work. We have a very well-defined value proposition. This was said about 60 years ago, and it is to provide efficacious and safe healthcare. And notice that efficacy is ahead of safety. So it is my work to deliver the most efficacious approaches to care that are available around the world. We have 6 sub-megas. I'll just highlight one of them today, and that is the systematic delivery of superior outcomes exceeding the most demanding international standards. So this is, of course, aspirational. It's very, very hard to achieve. But there's a very clear definition as to what is the direction in which the medical directorship and the administration in general is supposed to be headed. Now, the burning question for many of our listeners who are working in their countries trying to excel and who had training abroad and saw great outcomes in great institutions in Europe and the US and around the world and came back to their countries and are now trying to deliver that quality of care, I think share this burning question, and that is how to achieve the level of performance of the benchmark operating in an upper middle income economy or in other economies that are with limited resources. I think this is a question that all of us providers of care sort of host in our souls, and it gets you out of bed in the morning. Now I'll start talking about the style of leadership, which we discussed prior to this conversation, and our reference is a proposition that comes out from an author which is called Bob Dunham, and he coined the concept of generative leadership, and it's essentially a mindset in which people choose to transcend their own interests to contribute to a greater purpose. So once a month we have a conversation with the physicians who are entering our medical staff, and the central message is, if you come here, you're invited to develop, to construct an organization that will transcend you. And if you believe in that approach, in collectively creating something that is bigger than what you could do individually, then this is the place where you are going to be happy. And you'll have a very strong common sense of purpose. Now, here's where the pain begins, and structure must follow the strategy, and it requires enormous transformation of the way we see things and the way we've been doing it traditionally. So I'll present to you a tripartite configuration of the way we go about trying to deliver outstanding outcomes. So the first point is the medical structure, and we want to keep this in the back office. Patients are not interested in our medical structure, and frequently we are mistaken about showing them a lot about the details as to who is who and where you are. But patients essentially want to heal. So we are very careful about the medical structure. We have 15 departments and 3 institutes and so on, but we don't try to demonstrate this to the patients. We use it to keep our story together. Now, I submit to you that while all roads may lead to Rome, not all medical models lead to quality. So we, after about 35 years of functioning of the hospital, decided to write a book sort of dissecting which were the ingredients of our medical model. And we came up with 38 ingredients. And these are examples of those ingredients, which we actually converted into chapters. And each chapter is actually a position paper, a 3-page position paper as to what do we believe is autonomy, what do we believe is citizenship or quality or leadership. So essentially, we took positions on each of these 38 subjects and created this book, which is called the White Book of the Medical Model. And if I were to summarize it in three core attributes, I would say that we strive first and above all for person-centered care. Then we essentially perform everything based on evidence-based interventions. And finally, we work very hard to try to deliver homogeneous outcomes wherever we are present, wherever our brand is present. So these are the three guiding elements of our medical model. And we played with the value proposition and turned it into an equation. And once again, not original. You recognize these authors that are, classic authors when you talk about value. But the reason why this is useful is that if you essentially spend more in the bottom, you use more resources, and it doesn't produce any outcomes on the top of the equation, then essentially you are destroying value. So most of our conversations revolve around this equation, and you're invited, to add on the top and remove on the bottom, but not the opposite. And that is a very sort of straightforward way to approach the concept of value. We expect our clinicians to be entrepreneurial, to do patient care, to work in quality improvement, to perform research, to measure what they do, to publish it. And once they've done all of that, then they're welcome to educate, not before, but after they've done all of the previous. Now, the second approach to try to deliver these outcomes that I mentioned earlier are what we call the C4 program, which essentially relates to the clinical care programs of the Joint Commission. Some people may recognize them as centers of excellence. And we like to play with the word pro. And if you want to be pro, if you want to really be professional, pro comes from process. And if you want to excel, you really have to be fanatic about process. So we use all of the accreditation platforms as a very well-structured process of implementation of the evidence and hence leading towards better care. And of these hierarchy that I just outlined, I'm going to focus briefly on clinical care programs from a Joint Commission. There's a manual that has about 165 measurable elements additional to the basic accreditation, but essentially it strives for one roof, one method in disease-specific conditions or disease-specific certifications. And I think if you were to ask me what would predict success in this format, I would say that collective leadership is the principal attribute that is required to actually deliver great outcomes with this platform or any other that is attempting to achieve the outcomes of the benchmark. Now, this graph essentially shows our progress with all the centers as we prepare for evaluation. And the reason why I present it to you is because in no occasion we actually learn more medicine. What we learned about was process, documentation, standardization, great conversations, leadership attributes. And I think this is true around the world. The problem is not the basic knowledge of medicine or nursing. The problem has to do with getting your act together, with actually articulating process. So we now have 20 of these centers certified in diverse areas. I'll just show you 3 examples of what we have achieved that I would like to share with you. This is a combination. This indicator is actually a combination of blood pressure control, low density cholesterol control, and glycosylated hemoglobin. So I'm sure many of you know that if you combine indicators, the more you combine, the harder it is to get to the benchmark. And this is one where we can really show that if you combine these 3 and you get them within the benchmark, then the future of these patients in terms of mortality or cardiac failure or other cardiovascular conditions is going to be much, much better. So you can actually achieve an outcome that is as difficult as this one. This is an example of liver transplant where we are up there compared to international standards, and actually at a much lower cost. So very complex procedures like liver transplant actually can be achieved. And this is my favorite example. This is the youngest member of our team in orthopedics. My area is joint replacement. And here's Cristina Suarez, who is 28 years younger than I am, as you can see in the photograph. And these are our outcomes. These are 8 surgeons doing the same procedures in patients. And you essentially can see that there's very little scatter at 1 year follow-up with this quality of life scale. So despite 28 years of difference in experience, you can actually achieve great outcomes with standardization and process. And finally, we also work with a concept which we call clinical conditions and service lines. And for those of you who are out there and have financial responsibilities on the organization, we actually look at our products and in an axis, we look at its potential for tomorrow. And on the vertical axis, we look at competitive position today. And then we essentially come out with a scatter. And then we select essentially where 80% of our income comes from, which is of course a very reduced number of conditions, and we focus on those. So essentially, we compete from 3 different viewpoints and achieve alignment essentially through coherence of leadership and process standardization. And therefore, we work putting the medical model at the service of the mission and actually achieving our competitive strategy. And Dr. Sina, I'll just stop with this phrase, which I think we all feel continuously, and that is that whatever got you here won't get you there. And I think this is the appetizer for our conversation later. In Spanish, we don't say thank you, we say gracias. So I send gracias to all of you, and thank you for the opportunity of speaking this morning.
Thank you. Thank you so very much, Dr. Adolfo. And just listening to you and your own journey reinforcing that structure follows strategies. It is not the other way around. So how leadership and we all as healthcare administrators develop strategies which then follow structure. I want to compliment and congratulate you and your institution for amazing work you have done related to disease processes, trying to reduce variation. And I saw a very young man with another young lady who did wonderful job to reducing variations. So thank you so very much, Dr. Adolfo, for sharing your experience. And we definitely have some exciting questions coming up towards you when we go into our panel discussion. So I hope, ladies and gentlemen, you all are having you enjoy Dr. Adolfo's talk. Let us go to the second speaker of ours, Dr. Karan Thakur, and he is from Apollo Hospital Group, which I know many of you would know. I am personally, I have visited Apollo Group and have been extremely impressed with their vision, their strategies, and how in India, with the diversity as an enterprise they have, how have they managed to work towards bringing up this first of all, bringing up the vision and strategies, working towards the structures and processes, etc. So really looking forward to hearing from Dr. Karan. Dr. Karan, who is the Group Vice President and Corporate Affairs and Sustainability, is a very seasoned healthcare administrator and has been working with Apollo Group in the aspect of bringing the sustainability of quality and patient safety. So really looking forward to your talk, Dr. Karan. Over to you.
Thank you, Dr. Zeenat, and thank you, Dr. Adolfo. I think it was a great learning experience to really hear from you, outline your vision and very inspiring vision and how you're implementing it. I hope my screen is visible, and if so, I will begin. Thank you, first of all, to the organizers, IHF in particular, for inviting us to present how we look at quality, how we look at a systemic approach towards quality in a large organization that has a fairly wide geographic spread, but also a spread that has varying degrees of maturity. We have various hospitals, which are 4 decades old, and others, which may be very new or just being commissioned. How do we manage to drive quality through leadership, through KPIs, and through good governance structures, so that when you or when a patient visits an Apollo hospital, irrespective of the geography, they are assured of the same quality and outcomes that you would expect anywhere else. We know that one of the challenges, especially in resource limited settings and countries, is the pin code effect, which means that it's the luck of the lottery. If you live for example, in India, if you live in New Delhi or Mumbai or Bangalore, you may have access to good healthcare. But if you were to be, living in, let's say, tier two, tier three cities, you may not get the same level of care. How do we actually breach that, geographic inequity to make sure that at least healthcare, once a patient comes through our doors, is of a seamless, access and also of good quality? As we do that, I think it's also important to understand that when we talk about low resources, it does not only mean low internal resources, but could also mean low preparedness of the country's economy. You don't have enough quality players to act as suppliers. There is an entire ecosystem that is at work to make a hospital successful. And low resources could also be a lack of development of various, industrial part of the delivery of medicine. So that is also something that I'll touch upon, because when we started Apollo Hospitals 4 decades ago, we did not have that advanced industrial base within the country to actually service our requirements of delivering quality healthcare. At the same time, when we talk about resources, it is not limited to only resources which are of financial nature, but could also be of human resource development and others like of governance structures. Be that as it may, I just want to give an outline of the Apollo Hospitals Group. As I said, we were instituted in the year 1983. Our first hospital came up in Chennai. Today, we have 70 hospitals across India and operate about 10,000 beds. But along with that, we've also become the largest integrated healthcare entity. And what that means is that we are not limiting ourselves today to hospitals, but we also run specialty services through clinics, which are basically community-based, have a smaller footprint of inpatient care, mostly looking at diagnostics and care delivery in the outpatient setting. Also do a large portfolio of digital health services. And as you would see on the extreme left-hand side of this slide, we have created a digital front door called the Apollo 24/7, which if you read the slide from left to right, you access through a digital backbone all of the services that are available to us. This actually gives convenience for patients, but also adds a layer of complexity to ensure that we deliver clinical outcomes and quality across all of those touch points. So that's an added dimension, but one is willing to do that because it improves accessibility. And I think Dr. Adolfo also touched upon that in the latter half of his presentation. All of this, the delivery touch points, ensuring that we have good quality outcomes, give services of superior quality, and actually leverage technology, all comes under a bedrock of ensuring that those clinical outcomes are given in a financially prudential manner. We are making sure that we have a resilient delivery mechanism through supply chains that are robust, and also ensuring protection of our assets and those of our patients, because of cybersecurity and related privacy concerns that we have in healthcare. So when we integrate all of these together, one is the touch points, which you see on the left-hand side of this slide, and the other is clinical outcomes backed by a very robust financial architecture that ensures both the sustainability, the financial sustainability of the organization, and continuous delivery through resilient supply chains and security through our cybersecurity frameworks. Now, let's just build this down into what the hospitals and the healthcare division looks like. We have a large footprint which delivers very large clinical volumes. And this is important to sort of put out there because it adds to the need and importance of our quality frameworks. Because ultimately, to deliver some of these numbers, you need to have a very robust engine of quality delivering those outcomes. So currently, as I said, we are a large organization which has about 70 odd hospitals, 6,500 pharmacies, 450 clinics, and this generates a large volume of care episodes. Since our inception, we've done close to about 26,000 solid organ transplants, several hundred thousand cardiac surgeries, neurosurgeries, and treated close to about 3 million patients. This has also been driven by technology, which I'll touch upon in the in the middle of my presentation, but again is embedded with a very keen focus on accreditation, which we sort of brought into the country through the first JCI accreditation in 2005, but have continued to see the value of accreditation as a driver of both stable processes but also continuous improvement. So 8 of our facilities are JCI accredited, and close to 37 are accredited by our national accreditation agency called the NABH, which gives out accreditation to high quality health institutions. So in sum and substance, close to about out of 70 of our hospitals, close to about 50 are covered under A accreditation umbrella. Along with this, as I said, we've been very keenly focused on bringing in technology. And the reason is not just to be the first in the sector to bring in technology, but we understand that technology also is a driver of quality and safety. As we advance in medical technology, we know that some of the outcomes can be better managed. Some of the outcomes that are challenging can be actually better controlled, for example, through robotic surgeries, where through the implementation of a robot close to in 23 of our hospitals, we've seen reduced A loss, we've seen reduced post-surgical infections, we've seen reduced surgical site infections. So driving technology is not just to become the first, but to improve diagnostics, improve quality of care and outcomes, and also at the end benefit the patients through faster, cleaner, and more exacting diagnostics, and also a better throughput as the patient moves through our healthcare system. So I won't read out all of the interventions that we've done, but periodically and systematically, we've introduced new technologies for India and in many cases in the region. For example, other than our robotic systems, we've brought in the proton therapy for cancer, which is the first in Southeast Asia to be delivering that sort of care. So again, as I said, this is a key driver of our quality. When we look at our quality program, we've really looked at it from the patient first mindset. So under this, we are looking at 3 excellence models. There's clinical excellence, there is service excellence, and then there is the execution excellence. Under the clinical excellence model, we are looking at a centers of excellence approach, which Dr. Adolfo also touched upon. This looks at super specialty care being a self-driven a unit where across our hospitals, we have various KPIs being measured for that center of excellence. So for cardiology, it will have very specific to cardiology metrics, which each of our hospitals has to follow, report upon, and then is also marked against not only our practitioners, but also the medical leadership. There's a focus on outcomes, which I'll touch upon, the framework that we follow, which is done through a systematic systems and SOP protocols approach. The second engine is the service excellence, which is to make sure that patient care plans are actually attuned to the patient's need, and each patient, through those millions that you see that come through our system, have a care plan that is made unique to them through a multidisciplinary approach, ensuring that there's a continuum of care even after the patient leaves the hospital. The other is to ensure that there is good execution excellence by not only just engaging our staff, but making sure we deliver good quality care with a focus on financial prudence, as I spoke about earlier. Now, the quality framework is quite vast. I am just talking about four pillars here, which may be of interest, and these are something that drive the bulk of the 80/20 of our quality outcomes. The first is a zero harm initiative, which looks at how staff look at quality initiatives, and this is really driven through a daily meet of the unit level staff, which has a meeting for 10 minutes every day to look at what happened the previous night, what patient episodes are we looking at today, and what are the outcomes that are expected or unexpected that are likely to pan out during that shift or during the next 24 hours. This gives a good rounded picture for the entire care team to look at any untoward incident that may come and ensure quality is then reinforced or delivered. And this, as I said, is a collaborative approach. The second is actually monitoring the outcomes. And this we've done through a scorecard that looks at 44 parameters under the Apollo Clinical Excellence or the ACE model that looks at various interventions, looks at complication rates, mortality rates, and I'll show what the scorecard looks like in action. The third is we know that antimicrobial stewardship is increasingly becoming important as we see AMR rising, but also at the same time ensuring that we don't have surgical site infections or ICU related infections, which not only delay the recovery of patients, but can lead to a cascading effect, and ensuring that they are stemmed at the right time is one key focus that we've done both through prevalence surveys that we do, but also digital tools to track them. So again, technology playing a key role in ensuring that we ensure outcomes. And then there is an outcomes review, which looks at integrated clinical audits and a mechanism to then report upon that. So as I said, when you look at clinical parameters, the ACE is really benchmarking itself against the best standards that are out there. So when we look at the outcomes, the benchmarks that you see in the middle of the slide, we are looking at the Mayo Clinics of the world, the Australian registries that publish data to really look at how well our hospitals are performing against those. Now, one would say that given 70 hospitals, some at various levels of maturity, some are 40 years of experience that you have, others that may be just 3 years old or just commissioning, how do you actually measure the quality one against the other? And we need to be more equitous about it. So what we've done is we've divided the hospitals into three categories. The A category hospitals are the most mature, see the largest throughputs. So these, as you see, would be in our bigger cities. The B grade hospitals or B level classification of hospitals are in tier 2 cities or that have just achieved mid maturity. And C are those which are either very small in their footprint or have just come on board. And we actually manage to monitor the outcomes under the ACE 3.0 parameters for all three separately, therefore giving a chance for them to improve, but not making them be measured against something that they cannot achieve or will take time to achieve. So that way, at least we have a better, more harmonious look at where we are. All of this is undergirded by the Apollo Quality Program, which looks not only at the six IPSGs of JCI, but also effective communication, surgical safety, medication safety, and blood transfusion safety. And again, each of our hospitals is given a score, which then aggregates into this score that you see on the right-hand side. The 91 score is for 2024 for all our hospitals put together, the highest being 100. So again, this is a monitoring tool that gives a good scorecard for hospital leadership and the governance mechanisms to look at performance on the ground. And that delivery of that is done through what we call the journey to no harm, which looks at quality initiatives at the grassroots, at the patient bedside level. And this, as I spoke about, includes daily tiered huddles, looking at clinical pathways. We now close to about 25 clinical pathways for various surgical and non-surgical interventions, looking at accreditation and making sure that we are well prepared. And this is not just to be prepared for the survey, but ensuring that accreditation becomes a part of the culture as we drive towards accreditation. Monthly scorecards, clinical audits being another very important part of this, digitization, quality improvement projects, and a quality toolbox to see if a hospital is not performing well, what are the learnings from other hospitals in our system that can then be used here through the quality toolbox approach. And lastly, reward and recognition. it's very important to get a pat on the back to make sure that the efforts that you've put in are duly recognized but also rewarded. So when we look at enablers of quality, this slide becomes very important. And you've seen some aspects of it, but this sort of sums it up and brings it together. The first enabler, which is the most important, is the governance structure that we put in. Our mission, which our chairman, Dr. Pratap Reddy, put forward in the year 1980 when Apollo Hospitals was instituted, has not changed for 45 years. We still follow that vision that he set out to ensure quality healthcare being available to every Indian or every citizen or every patient that walks through our doors. And that visioning helps us actually drive all of the change that we have brought in over the past 4.5 decades. And it's really that vision, making sure that that does not change, ensures that everybody who joins the organization at whichever level of our hierarchy follows that single mission. It does not change for which part of the organization you work for. So governance becomes important. We have board level oversight over quality and outcomes. There is oversight at the operational level and also at the clinical directorate level to ensure that those figures that we just showed are not just reported for the purpose of reporting, but are actionable. Data is a key driver. If we don't measure in a large organization like ours, we will not be able to effect change. So how do we capture data? How do we use technology to capture that data, identify risks, make sure those risks are mitigated and stopped through audits? Being a continuous exercise is important. So data becomes a very important tool. Monitoring and surveillance, which you saw through our ACE platform, make sure that month on month we know what is lagging, what is improving. And then you have to have programs like Journey to No Harm, which is both organization wide within a hospital, but enterprise wide between organizations. And training and capacity building is the most important aspect that we find has been a game changer for us. Last year, the Apollo hospitals actually gave 2.1 million man hours or woman hours of training to each of our employees, ensuring that they are up to speed on the expectations on SOP performance, but also on the expectations on how they are supposed to deliver on the job. And various sessions, for doctors, nurses, managers, to make sure that we have a good level of advancement in our understanding of what is the next thing out there for clinical excellence and the delivery. As I said, cross learning between hospitals is our strength. What Delhi can learn from Mumbai is something that probably we cannot even learn from the outside in, because we understand each other's systems and can help improve each other. So there's a collaborative approach that we see. We're also looking at clinical innovations, making sure that they're introduced timely and they're delivered for patient benefit. Research, academia, not a lot of private enterprises actually talk about this, but this has been something that has propelled our clinical outcomes. Currently, 55 studies and over 100 clinical trials are ongoing. And as I said, accreditation is a very important part of what we do. So with that, for the paucity of time, I won't delve into all of those in detail. Happy to take questions, and thank you for your time and attention. I'll hand it back to Dr. Zeenat. Thank you.
Thank you so very much, Karan. It has been really inspiring journey of Apollo, and thank you for sharing it with us. And I was in Delhi, New Delhi Hospital, where your ZepX was being installed, and I was absolutely wowed with that technology and the energy of your staff and your clinicians to work towards technology to improve the patient outcomes. So thank you for sharing. And I loved your ACE example of how you are monitoring such a huge enterprise with variation in the type of hospitals you have. Definite some questions are coming up onto your side. Just hold on to that. We will be asking some questions in a bit later once we finish our third speaker's presentation. So our third speaker is Dr. Afke de Graaf. She is a dear friend of mine. Dr. Afke is our director of is the director quality at Farm Access Foundation, and Farm Access Foundation works and has very innovative framework of patient safety and quality certification, which is called Safe Care. And I personally know the benefits of Safe Care in East Africa, in not just in my own institution, but with the public institutions, government hospitals, missionary hospitals, where Safe Care has provided a solid framework for institutions to improve upon in a very structured manner. So, looking forward to listening to Afke of the journey of Safe Care and how the journeys of these other institutions have been. Over to you, Afke.
Thank you, Zinat. And let me share my presentation. 1 second. I hope it's there. Thank you so much, Zinat, again, and thank you everybody for joining. I'm really excited. Thanks also to my co-presenter. Really nice presentations. And I would like to start with, we're talking, of course, about quality of care in resource-poor settings. And my organization has offices in Kenya, Nigeria, Tanzania, and Ghana. We work in 25 countries. But this is actually why we do it. If you look at and I can imagine most people know this sort of unimaginable number. 5 million people per year are dying due to poor quality healthcare. And I think that's unimaginably, but we all know the examples why that happens, why those preventable deaths. If a doctor doesn't wash his hands and you get the maternal sepsis, you don't do triage well, and antibiotics are prescribed too late. So I think we all have the examples, and especially in resource poor settings, really the bottom of the pyramid where we work, we see those examples. We also see that there like you said, Zinat, there are many challenges. The approaches that are often there, or the accreditation systems, are expensive, time consuming. But we see the small facilities with limited HR capacity, limited financing, of course. We all don't have the goals, but these facilities really have even not a proper infrastructure to have provide good quality care. Additionally, they don't have the knowledge. They don't know where to start with quality, and there are limited incentives. And of course, incentives are, in the countries where we work, one of the key areas. Do you get, for example, higher differential reimbursements if you provide better quality care? That's usually not the case, unfortunately. So what do we see? These are some data that of facilities where we work with, where you see that, unfortunately, the gaps are huge. You see that of our group of facilities, most of them start at a low level of quality, with 34% having waste management compliance. You see only 26% compliance with protocols and guidelines, 16% resuscitation, and 24% having a triage system in place. So if you look at these numbers, you know there's a lot to improve, but how do we support those facilities to provide that structure? If you look at the framework we have, it's all about what we see as structures, processes. And if you look at what is important, of course, most frameworks have a yes or no approach, where you're either accredited or not accredited. Whilst these facilities, if you start at a low level of quality, you just want to know where you are with your quality. So we start with a gap analysis, provide them their current quality of care and of their level of quality, and we provide them with step-by-step small tasks to improve their quality. Our standards are ISCO accredited, but especially the part about providing them with data insights, showing them where they are, to eventually, of course, drive improved health outcomes with the focus on person-centered care, evidence-based intervention, and all the things that also my co-presenters presented. Quality improvement, like we said, it's a journey. It's not that you start and tomorrow you have good quality care. So it's really about knowing where to start, how to take those steps, and start small. And you see here the 5 levels of quality that we have. Low level of quality is really you start to improve. Well, it's the lowest level of quality, but over time you can improve your quality to higher level of quality. And a level 5, and I will give some case examples later, is the highest level of quality in our system, where usually we promote facilities to go to accreditation if they have a level 5 facility. These standards, of course, are like the JCIs, like all the other frameworks, focused about structures, policies, leaderships. And you see here that our standards have management, clinical, and clinical support service elements, like we call them. But there's human resource management, there's risk management, there's waste management. There are, we're of course now in a webinar for Geneva Sustainability Center, where it's also about efficiency. Yeah, do you have do you maintain your equipment? Do you have proper supply management, waste management? It all helps to improve efficiency, and of course eventually helps you improve your business as well. If you look at all the different other criteria that we focus on, a lot of them are clinical. Like I said, the triads. Do you use PPE? Do you have infection prevention? Do you label your specimens? Of course, do you use your guidelines? But also, HR, is the number of staff fitting the number of patients that you have? So it provides you with a structured approach. We start with, well, the most impactful criteria, of course, to start improving them. Obviously, an operational quality structure is one of the most important things to start with. This is an example of the data we're evaluating. And of course, it's detailed, but it says something about, this is a QI activity. Ensure the storage area has various supplies, of course, and that they have sufficient space, that it's ventilated, that's well organized, and of course, it's locked. And the nice thing is that you have here, it's of course a snapshot from how we communicate with the healthcare provider that use our approach, where they said, well, this is what has been recommended. They upload a picture on our tools, and then we can check on a distance, okay, are they working well? Can we provide any additional advice? So it's really, quality is really about this, having a gap analysis and focusing then on how can you get a continuous focus on quality improvement. Well, that's again also how we use it, the digitalization. During COVID, this is something that really supported us a lot, because we couldn't support facilities due to the lockdowns, but through to our digital apps, we were able to communicate with our healthcare providers. But it also provides, well, what are the incentives to work on quality? It provides some benchmarking. Am I doing better than my neighbor? Gamified feedback support. It also shows you, well, the data, where's your progress, and also training, where do you need to focus on? This is an example, infection prevention. Well, we all know this is one of the most critical things, and you see here that facilities, when they on average start, are around 34% compliance, and at the end line of our program, 73%. So that's huge improvements. These are the gaps that we focus on. Hospital systems, processes, nurse, midwife capacity and knowledge, and respectful care for patients. And of course, the target is to work towards replicable quality improvement systems, professional development, and patient-centered care. And well, it's also always nice to see, well, what kind of big achievements, what you can have. And you can see here an example in Nigeria. Well, I think everybody on the left can see that they were at the start of their quality improvement journey. And if you look at the right, this is a hospital with a very dedicated staff. And if you have that committed leaders, you can see what an impact you can make. And of course, it's also not a one-day journey, also not a one-year journey, but if if you follow the structure, yeah, I see there's an applause. I think it deserves an applause. And I have some other nice examples as well. This is another example of a community health center in Kenya, where they approached us in Nairobi well, they heard about our framework. And you see that over the years, we started with the first assessments, where we, over the years, visited them, supported them with TA, supported them with our library, which has templates, because you don't need to reinvent the wheel. It's really about, is there a structure? And for example, checklists. You don't need to reinvent the wheel. You can just use what the WHO has, and we help facilities to make it easier, to make it, well, not fun, but to help them take those steps achievably and simple. So what you saw over the years is that, well, they really grew in their quality. They first established an improvement team, started to work on SOPs, on the documentation. They grew towards weekly improvement meetings, sending out patient satisfaction surveys, collecting those health outcomes, starting with how are we really doing, then hiring a quality improvement officer, and setting up a clinical excellence department. And this facility, well, this year grew towards a level 5. So, and I think that is, well, you see that took them from 2017 till 2025. But you see, and the impact is sort of in the right lower corner, but you see now they have a 97% in patient satisfaction, and most importantly, 50% reduction in neonatal and under 5 mortality. So big achievement from their side as well. And then the last example, this is Pelon. It's also a facility that we support in Nigeria, which also well, has done quite a journey from safeguard level 2 to safeguard level 5, also from 2014 to 2020. But again, here, Dr. Ngozi is the medical director, which of course has a team. It's about collective leadership, but it usually takes one person to say, this is what we're going to do. What you see is their key improvements, of course, policy, procedure improvements. They expanded their facilities, they hired new people, they reorganized their patient flow. And what you saw, and I think that's a really clear sign that's important to also say, why do you need to work on quality? Of course, it's the patients. We want to provide good, well, safe care. But if you can see here, this facility, and we have many examples of that, if patients recognize that there is good quality care, and of course the certification helps with that, you see that patient, there's word of mouth. People talk, they say, you need to go to that hospital. And in this facility, they saw 180% growth in revenues, more than 300% increase in patient visits. And they were also one of the key facilities that were used during COVID. And this facility, you can see on the next slide, it is one of the facilities that also celebrated, because every step you take, you need to celebrate. And you see here that they received the Nigeria award for best facility. You see that all the improvements, the certifications were celebrated. And I think that is key to really stimulate the culture of quality that you need to have, and also show your neighbors, do this as well, because it's helping your patients. So to finalize, my personal learnings over the years, I've been now with Safe Care for the last 7 years. We have a partner approach. So we work through our partners and they implement it. And so we've quite some experience now in 25 countries, but in all countries we see that, especially the first part, starting with the gap analysis, that's when you say, okay, now it's clear. A lot of facilities think, well, I'm doing quite well. I have good doctors indeed, like Adolfo said, but it's really showing, okay, what are the processes that are in place? What are the structures? And well, unfortunately, we often see that's lower than hospital leadership thinks when they start in the journey. So start with the gap analysis. Take small steps, use a framework like ours. You can use every framework. A lot of countries have frameworks, but without a framework, well, doing it on your own takes time and it's not needed. So don't reinvent the wheel. Leadership. One of my directors in the country says it's all about leadership, 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 and that's something that we see. Stimulate a culture of quality. Focus on it, and digitalization can help with that, but continuous focus is needed. You can't say every half year we look at quality. I think, well, that's clear. And I think with our examples, with 80% of our facilities is improving. You see the journeys of those case studies that I just, you can do it as well, also in low resource settings. And the most important thing is celebrate, because that keeps you on moving. Thanks, Inat.
Thank you so very much, Afke. Very, very practical and amazing presentation. Your examples of these institutions in various countries it gave me a lot of hope that, you know what, we can do it too. And the fact that let us not reinvent the wheel. There are frameworks, and we talked about it. Adolfo and Karen talked about JCIA, SafeCare, COSESCA, UK, and I mean there's so many of them. Let us use the available frameworks and not start blindly. All right, ladies and gentlemen, that was amazing panel discussion from three of our speakers. I would like to now open up some question answers, and I will moderate it. You have been requested to put your questions in the question and answer session. I have a few questions already. So let me start with Adolfo and Karan, both of you. Please, Adolfo, if you could start. How do we address burnout and workforce shortages while still promoting a culture of quality and safety? Very valid question, especially in countries we work in. We don't have enough staff. Shortage of staff is so common, and burnout too. So, Dr. Adolfo, what is your thinking about this question?
It's a central question around the world. I will pose the following hypothesis. I think it is very important when you recruit or when you admit staff to your organization to be very clear, very explicit as to what is the nature of the invitation they are receiving. In our institution, we invite them to be part of the construction of something that will transcend them. That is the central element. Now, our model is a model that pursues outcomes that are attractive to anybody who came into healthcare to serve. So I think if you have a very strong sense of belonging, a very clear sense of purpose, and you are in agreement with that, with the model, a model that feels natural to you, then I think the probability of having a burnout is much lower than if you actually go for a job and you feel uncomfortable in that environment. And I think we've all been around institutions, and there are some that they just fit like a perfect shoe when you're there. And they don't have to be pretty or ugly or rich or poor or new or old. It's just the culture. You just feel it. And you feel congruent with the culture. And there are others that you feel very uncomfortable with it. So if you listen to that interior voice and be frank about that match, I think that's the starting point. I think if you follow any of the patterns that like Dr. De Graaf was presenting or Dr. Dahoud, and you're working towards improvement, I think it's the most dignified way of serving. It brings dignity to the individual. It brings pride, and it brings joy in the workplace. Now, here's the kicker, Dr. Zina. I think you really have to measure that, because I've had the experience that when we started measuring, and we use Great Place to Work as the platform where we measure culture, I was shocked by some of the evaluations that I received. They had nothing to do with my intentions. They had nothing to do with my personal motivation. And nevertheless, I was transmitting messages that were poorly received. So really measuring what the people are actually feeling, being humble about the incoherences of leadership, and about the objectivity of promotions, and the quality of their recognitions, and the level of communication, and all of these soft issues that are there, is key, because intentions are one thing, and what actually people perceive is completely different, unless you have a very solid, robust structure. You will find that you have microclimates. Some areas of your institution are very happily aligned, and then you'll find others that are not, and you have to address those microclimates, and you have to emulate those that have done well, and so on. So I think that in one sense, if you are in alignment with the sense of purpose of the organization, and you're able to actually be coherent, I think the probability of having burnout or having high turnaround of your staff is very low.
Absolutely. Great strategies. Great point. Thank you for sharing your experience, Dr. Adelfo. Karen, if I were to, there's a question related to specific to you, would be how do you, uh, uh, I would like to ask you, how can healthcare system in LMIC ensure accountability and transparency in reporting quality outcomes? Great question. Great
It's a
question.
great question. Yeah, and I just want to also just add on to what Dr. Adolfo said. I think, doing a culture of safety and also staff satisfaction surveys, they're quite important to get a mood of the organization and as anonymized as they can be. And as he said, sometimes you'll be surprised by the various areas that you expect that there might be trouble, there isn't, and others that might pleasantly surprise you. The other is having an anonymous way of reaching out so issues can be reported in a timely manner. I think that's something that is very important and can help reduce some of the burnout. To the question specifically to me, I think it's a very important one. One, we have to realize that as a patient becomes more empowered, especially in LMICs, there is no place to hide. The lack of quality, poor outcomes, or worse, will come out in some shape or form. It's very important that we don't assume that the patient is not empowered enough to actually make his or her voice heard. It may have been true a few decades ago, but it is not true anymore. There is a changing aspect of how patients now consume medical services, and there is the paternalistic attitude towards medicine has greatly changed towards one where I am receiving the best care possible as a service, and being very mindful that this is the best person who to deliver it to. So I think we need to first be very clear that even if we don't build a culture of transparency, the word will get out, and while you hear it or not, the community will hear it. The wider dissemination of that through social media and other means will happen. The other is the safety of the safety for patients is as important as the staff safety. That there's a culture of safety to actually come out and talk about mistakes that may have been made, correctives that may be required. And I think that takes a lot of leadership. It takes effort, and it takes courage also to say that, look, I'm going to raise my hand up and say, on this particular issue, in this particular OR, there might have been an issue that went or that deviated from the SOP. This is how we do a corrective. Third is from the systemic approach. How can we actually, and catch is a bad word, how can we actually have good surveillance to see that there is something that is going on in a unit or ward, which is either too far from the mean in the good or not performing well enough for us to maybe drill down a bit more. So on 4 counts, one, an empowered patient. Second, a culture of safety that, psychological safety where you can talk about issues. Third, leadership. And fourth, good data monitoring.
Very good. Thank you, Karan, for a very, very elaborate response. Afke, an interesting question. How can we impact or scale up by engaging public institutions and inspire them to adopt quality framework? And that's true, because private in LMIC especially, majority of the population is going to public institutions to seek health care. How do we encourage them? How do we bring public institution? And really, the next question is also talking about the same thing, that if you don't have resources, how can we get some funding avenues to bring quality under an umbrella? And I think that also is very pertinent to public institutions as well as not for profit private hospitals. So, Afke, what do you think? What is your experience about it?
Yeah, really nice question. And I especially think in this, well, this time with now USAID funding, well, having been freezed, we see in a lot of countries where we work that the funding also of the public institutions really went down. So I think there, this financing and really seeing how can you still focus on quality is one of the things that we really focus on. So in the countries where we work, you usually see that there is a quality framework in place, but it's really about really sort of the certifying, is this facility, well, can it be a hospital? And usually that's not a focus on quality. So what we do in the countries is we work with them, see if we can support them, well, with our quality improvement approach. So really the steps that we take. And there are some countries that, for example, now in Kenya, we're going to look how we can support them with quality improvement, and especially providing us with the digital tools that we have. So I think there is a lot of interest from the public sector. What we also see is that the public-private partnerships are key here, because of course quality in most of the countries where we work, you see that over 50% of the facilities are private facilities that patients go to. So how do you balance that? And I think, well, frameworks like JCI are usually applicable to a few facilities in Kenya. So therefore, working together with private and public, seeing how you can use different types of certification and accreditation systems together to improve quality of care, and at the same time see how you can, of a whole country, improve the quality as a whole by collaborating. And we're very much open to, and we also work with a lot of public institutions to support them with quality standards. So we work in Kenya, we work with several sites in Nigeria that use our methodology. So it's all about working together to reach that aim.
Absolutely. You touched upon learning from each other. And I think one of the questions is that private hospitals might want to open up their training to other hospitals. And I think it's the other way around as well. The institutions need to be learning institutions. Individuals need to be learning, seeking a new knowledge. And sometimes there is so much available now on if I know that if I go to Apollo sends so many, they have so many CMEs, so many wonderful quality related, which they open to public. And the same with our network, Aga Khan Development Network. We open it to public. IHF, FHHS, I'm sure Dr. Dalfo's institution. So there is so much of training and sessions which is available. I think we don't need to worry about cost in everything. There are ways of accessing expertise by reaching out. And believe you me, I can speak, I know on behalf of institutions like Apollo and Aga Khan and Adolfo, your institution. Reach out and our doors will be open. So again, ownership is on the institutions and individuals to also look out and look for opportunities to improve. IHF, FHHS, Safe Care, there is so much offering going on outside the thing. Let me ask this question, Adolfo, and this question is coming to you, and I think it's an interesting one. If you had to choose, would you prefer technology or process? I think that's a great question.
I agree. It's a great question, but it's an easy one to answer. I would certainly choose process over technology. It is humbling to learn as you standardize how very simple actions actually deliver extraordinary outcomes. And perhaps the best example is the prevention of infections of indwelling catheters. When you look at the protocols for that, they are very simple interventions. The hard part is doing them all at every time, every single time. So I think we are frequently distracted, when we travel to very developed economies where resources are abundant. They're never enough, but they're abundant. Then you come back to your country and you wonder, how can I, reproduce those outcomes in my environment? And I think the secret is in that question is that it is about standardization. The knowledge is digital. It's everywhere. In every corner of the world, when you travel, you find fantastically motivated healthcare workers who are very knowledgeable. What is complex, and perhaps I remember a phrase by Donald Berwick in the US who said, it's not rocket science. It's harder. It's people science. It's getting the people to interact. In our structure, Dr. Zina, I will tell you, we have this crazy structure of orthogonal leadership. And I'm sure it's the same for Dr. Karan in Apollo, where when you create structures that have different dimensions, all of a sudden you have, very young people. My boss in orthopedics is perhaps 30 years younger than I am. But at the same time, I am his boss from the medical directorship, and developing the ability to work in a collaboratively without feeling threatened, and actually being able to collaborate without stepping on somebody else's toes in these very complex matrices, which are typical of what Dr. De Graaf actually does, because these improvement standards create very complex matrices.
Absolutely.
So it's about process more than it is about technology. Technology is always welcome, but process. And I'll tell you one more thing. The less resources you have, the cheapest hand labor is going to be. So getting hand labor in developed countries is very, very expensive. Getting hand labor in countries like mine is not so expensive, and that's where the power is.
True. Dr. Dalfo, can we clone some of you guys and really get to know more about how amazing work and how you are doing this integration? Because truly speaking, you are right. These are the complicated human relationships which makes, or sometimes unfortunately breaks, the strategies could be solid, but we can't meet our vision. So wonderful. Thank you very much for sharing your experience. Karan, Dr. Karan, I have a question for you, and that is about you guys are very successful in Apollo, and it has taken time. Your journey has taken time. Why and how do you continue to be inspired to be the leader in quality and patient safety? I mean, how do you keep up with that vision?
I think that's a very important question, Dr. Zeenat. I think it has a lot to do with leadership, our organization leadership, always wanting to do more. Our chairman is in his mid-90s. You meet him still, he's asking us, Karan, what are we doing next? Are your patients happy? How is your hospital doing? What best can we do for them? And always insistent that we do patient rounds, whether you are patient facing or not. Go and meet 5 patients. I think that's the driver of quality and excellence. So I think that the nutshell is there. Beyond that, I think and without sounding ahead of ourselves, I think when we started out, we wanted to be as good as the best institutions in the world. And today, I think we are competing with ourselves also, where we are wanting to do better than what we did yesterday. Whether we are better than other institutions is important, but the challenge is, are you better the next day? Third is, I think there's a huge demand and need still in India. I mean, where we primarily operate out of, for good quality healthcare to improve and become more accessible. So as we open new institutions, we need to make sure that that is extended. And that means that, it's not just another new hospital, it's an extension of 4 years, 4 decades of our legacy. So how do we make sure that that translates there? So a new hospital opening today, when you enter, the expectation is this is like Apollo Hospitals Chennai that opened up in 1983. So we've constantly got to improve. You're on mute, Dr. Zina.
You're on mute.
God, I'm so sorry. I was just saying, ladies and gentlemen, thank you for sending us your questions. I hope we have responded to your questions. Afke, I have one part of a question which I think you did respond to, but if you could just last shortly tell us how do you encourage working with the country's health system, especially public health system, to utilize your framework, and we will focus with you, and to manage quality at a public sector at a national level for the countries where we do not have. I know some of our countries do have. How do you work around it? If you could just give us one or two strategies you have utilized.
Yeah, so I think, yeah, good question. So the countries we work in, so those 4 countries that I mentioned, they have quality systems. Although we see that certain states or counties, it differs per. You also have this county approach, well, separate from the national approach. So we could also work on a smaller level. What we do is that we go and sit with our public partners and say, okay, these are the standards that we have. Does that fit you? Do you have any additional needs? For example, some countries really want to focus on maternal and childcare. We can then add it to our standards. So it's a combination of having a framework and really localizing it. And I think in addition to that, what we always advise is to embed it in the healthcare ecosystem. So how do you use those quality standards? How do you incentivize them? Can you do that through insurance? And I think those are the strongest networks that you can build, where payment and quality are combined.
Great. Thank you so very much. And there are some very exciting comments in the chat. Please feel free to read that. And this is when I am pleased to conclude this session, which I think has been amazing. What a great enlightenment. My job is to thank all the participants, and more importantly, the panelists who shared their experiences with us, and for responding to the questions. Thank you so very much. Aditi, over to you.
Thank you, Zeenat. So my job is to thank you for doing such a fantastic job of sharing this panel, and of course to the panelists as well. Thank you so much for your time and for your engagement. And likewise to the participants, we really appreciate you taking time out of your days to be here with us. On that note, we'll go ahead and close this webinar. For any questions, feel free to reach out to us. I'll go ahead and make sure our email address is there on the chat. And for the recording itself, it'll be available to you. We will send an email with a copy of the recording, so you'll have access to that as well. Thank you all. Have a wonderful rest of the day. Take care. Bye-bye.
Thank you, everyone. Thank you very much.